Thank you so much for that lovely introduction. I'll just correct something that I didn't fly from Perth on the red eye, which I have done before. I actually came down from Sydney, where I'd seen West Side Story on the harbour last night with a friend, in fact with Carol Bauer, who helped us with all the folate research. Yeah. So I just want to acknowledge the Wurundjeri people of the Kulin Nation, which we are standing on. I always do this, and in acknowledging it, I always say we have to acknowledge the impact of the stolen generation on families and children today, and I think that's really important. I'll just give it this being dry from the plane. Can you guys hear me well? Yes, good. So I feel a bit of an imposter here because really I'm not a clinician, and I have never really been a clinician-scientist, so that's one bit of being an imposter. And the other imposter thing is what Sam referred to is, I'm not a basic scientist either. And the trouble is that my brother Richard did his PhD with Don Metcalf on colony stimulating factor at the Walter Eliza Hall Institute. His wife Pamela did somatic cell genetics with Gordon Ada. My husband Jeff was Gus Nossel's first PhD student in immunology virology, working on natural killer cells. And of course my dad was a basic scientist virologist working on poliovirus. So I was the black sheep of the family. And so it's quite scary to give this talk to you, and I'm absolutely not what you really need. But Ingrid said to me, just tell them what you've done in your life and what happened. I think the other thing about being a clinician scientist in relation to what Sam said too, if you're a mum, it's even harder. Do you have your patients, your research, and your kids? I mean, it's not easy, but we might want to have some questions about that over morning tea, I guess. So, so I remember one of the basic scientists in my institute, who happens to be a wee high scholar, and he said to me, Fiona, your research is fluff. So epidemiology was considered to be fluff by the basic scientists. We'd actually just got our 4th consecutive NHMRC program grant at that time, and I sort of laughed at him, but still, that sort of thing still gets at you. So what I want to do today is convince you that epidemiology is not fluff, and it's a lot of fun, and it's incredibly important in health and medical research. So it's the study of diseases and problems in human populations, and its application is to prevent disease or reduce its impact, and that's what public health is all about. And of course, the most successful examples by a big margin is vaccination. For all the infectious diseases such as polio, smallpox, diphtheria, tetanus, pertussis, measles, rubella, influenza, and of course, COVID. But the epidemiological approaches aimed at prevention can be used for all types of problems, not just diseases. Over the last decade, while our politicians have battled it out in Canberra and tried to score points from superficial debates, they seem to forget that we are, as a society and a planet, facing serious and complex problems that not only require serious and deep debate, but the best complex data and evidence to guide decision-making. I'll talk about that at the end, because I've done a complete circle. So my life in research is mostly about getting data, getting the best population data and using it to good purpose. After medical school, getting interested in child health and observing the living conditions of many First Nations children in Western Australia in the 1970s. And I realised I was more interested in preventing diseases than treating it. I mean, I'm a failed paediatrician, basically. And I'm the only person to have turned down an offer of a registrar position at the Royal Melbourne Children's Hospital. We don't need to go there, that's fine. So now this first slide I will have, so I guess I just, someone better do that. Where do I put? Wonderful, isn't it? I'm usually pretty good in technology, I'm sure. So this is the sort of causal pathways that turned me into an epidemiologist, public health, child health researcher. So you can see colonisation, I don't have to go through it all, but what colonisation and genocide did is to take away all the capacity of Aboriginal people to survive with healthy lives, living as they did before. They've now gone into, many of them, into situations where the disease and social problems are inevitable. And of course what we've done is to fail to deliver any services that have actually impacted positively on that. So I think the thing that got me too was that successive governments had got it wrong and caused damage to these people rather than actually helping them And that was the whole thing about the voice, which is one of the most important. A lot of advocacy I've done, but I failed on that one, or we failed collectively. So the career in public health and epidemiology, when I was in medical school, I couldn't spell epidemiology. If I'd seen the New Yorker joke then, I wouldn't have even known what he was talking about. But I was particularly interested in children's diseases, and particularly the developmental disorders such as birth defects, cerebral palsy, intellectual disabilities, and mental health problems. And then they were all relatively neglected by epidemiologists. After several years training overseas, I'm actually very old. I can remember giving Sam an NHMRC fellowship 100 years ago. So there was no training in epidemiology and public health and biostatistics in Australia. So you had to go overseas. After several years training overseas, including the States as well, going and looking at where all the very good data collection places were in the registers for birth defects and so on, I came back and with a team set up some of the most comprehensive population data on these problems of developmental problems in the world. And we described how often they occurred, whether they were increasing, what were the likely risk and protective factors to enable preventive strategies to be developed. Our most useful innovation, not just that it was all population that was included in our data sets, it's incredibly important to avoid bias by getting everybody if you can. We developed methods to link them together, and I think, as Ingrid's referred, very few countries had record linkage at that time, but we modelled ourselves on the Oxford Record Linkage Register because we were very lucky that Professor Michael Hobbs had done his DPhil in Oxford on record linkage and came back and basically told us how to do it. So I'm going to put my career in context of epochs, if you like. But in the 1970s, the world was shocked by thalidomide. I'm not going to ask you questions, but I do hope you've heard about thalidomide and what it does to babies who are exposed in utero. Diethylstilbestro, you might not know, but just Google DES. And Agent Orange was the other one because this was the height of the Vietnam War. This led to our birth defects register so that we could detect early trends, search for potential exposures and avoid them. Secondly, it was a world where very preterm babies were being intubated and treated in NICU. The first intubation of a prem baby was in about 1948-49. So it's in the 70s it was just starting to really become a greater survival of those babies. And we'd never seen these babies in the world before, these very low birth weight preterm survivors. So we set up registers of cerebral palsy and intellectual disabilities, some of them with the epilepsy as well, and linking them to gestational age, pregnancy, neonatal conditions, and of course, outcomes. And thirdly, it was a world in which there were dramatic increases in electronic fetal monitoring and caesarean sections, and our databases could evaluate the impact of these on immediate and long-term outcomes. It was a world in which there was a dramatic increase in adolescent suicides, fourfold increase in males between 1975 and 1985. So we collected data on all suicides and episodes of self-harm and looked at possible interventions. In the 1980s, along came new treatments for infertility like IVF, which increased higher order multiple births, many of whom were preterm, and which overwhelmed intensive care units. And, of course, there were concerns about the developmental disorders. So we collected all episodes of fertility treatments and linked them into the database too. Asthma and allergies increased dramatically, as did type 1 and type 2 diabetes, with very different causes, as you would know. And childhood cancers started to be studied and treated more aggressively in many centres. And, of course, the rates of ear disease and other infections were making far too many First Nations children very sick and sometimes compromised for their whole lives. So-called cot deaths killed nearly 3 per 1,000 live births every year in the 1980s. In the 1990s, we had a dream for an institute, different from any other Australian at that time. So the kinds of things that Sam was talking about collaboration across all of the different areas, basic science, clinical science and population science. No one had ever thought of that. And I remember when Gus Nossel, who was Australian of the Year as well, came and gave a talk at our institute, and he said, well, when Fiona told me about setting up this institute, I thought she was crazy. So it's interesting. But now he said, you are exquisitely poised with the Human Genome Project to make use of all the data that we have. So I realised, though, that epidemiology alone wouldn't solve the problems of causation and looking at these causal pathways. So we'd need more than fluff. the population scientists needed to collaborate with the basic and clinical scientists to be able to bring a sophisticated approach to causation. Adding basic and clinical expertise to our data, our cohorts, our randomised controlled trials meant that we could test in the human infant and child the ideas coming from research models in rats and mice, cells and genes. This was before the Genome Project, but of course, through the 90s, we also had access to much better genetic data. And I recall my husband Jeff saying that what was unique about our institute was not the basic and clinical sciences, but was the population data. And, it was trying to get all that to marry together to make a difference to looking at causal pathways. But it's very good doing epidemiology in Western Australia. It's got a very small population. There's a desert on one side and a sea on the other, and we've got them all in the middle. 30,000 births a year at that time, and we made it into a total population laboratory, an ongoing longitudinal database which included all children throughout their lives. But with our small sample size for some rare conditions, of course, we needed to collaborate nationally and particularly internationally. And it's extraordinary, but in a place like Western Australia, Helen Leonard, who's a neuroepidemiologist, set up a international register of Rett syndrome, probably one of the rarest genetic diseases, 1 in 20,000 females. And so we got all this data from all over the world in Western Australia. And it's very interesting how individually rewarding such information can be, because, of course, then they got the MEP2 gene that's on the X chromosome, and they were able to identify these mutations. And we actually had the tooth of one of the children who died in one of our studies of unknown cause, and we could reassure the mother that, in fact, the child had Rett syndrome. So, they're the nice things where you start marrying clinical and basic science. But we had very good examples of collaboration across the divide of population, basic and clinical sciences, particularly in asthma and allergy, with Pat Holt and Peter Sly, who were just phenomenal in using our population data for all their, if you like, all their sort of clinical and basic science hypotheses. We had childhood cancers developed with Ursula Keys, so every single child who had cancer in Western Australia is in one ward. They all got their cell lines grown by Ursula, and because we were part of the International Child Cancer Network, we were actually the first in Australia to become it, which I thought was quite pleasing, because I thought Melbourne would get a bit pissed off with us, which they did. But every child with cancer in WA is part of an international randomised controlled trial for cancer therapy. So you can see just how important it is to have those linkages together and to use them. And the collaborations in infectious diseases were really powerful, with studies from both First Nations and non-Indigenous children. Deborah Lehman and Peter Richmond set up cohort studies of otitis media. Jenny Blackwell, who we recruited from Cambridge, established a genetic epidemiology of both otitis media and other infections. And with Geoffrey Hanna, who's a paediatrician, the only PhD student I had who said Perth was too big, and he left before he finished his PhD, but that's another funny story. He set up the first meningitis centre in Australia, and now Bruce Longlont, a parent, is chair of the International Organisations of Meningitis Centres, and they do a lot to do prevention and management. But there was little collaboration in mental health with the basic science, but great collaborations with clinicians in all the developmental disorders. And as conditions like autism and ADHD appear to be increasing in our data, these registers were most important as we could link the diagnoses back to pregnancy and early life factors, and that's becoming very, very important. Well, did our not very fluffy total and linked population databases with additional cohorts, case control, genetic epidemiology serve a rich agenda? You betcha. Using the databases, systematic reviews, clinical and basic scientific findings, we developed hypotheses of causation to test with the hope that they might translate into preventive strategies. The additional value of the linked longitudinal data is that we could relatively easily see if we had made a difference, in whom, and possibly describe the characteristics of those whose outcomes did not improve. Really important evaluation of a service based on research findings. So, going back to that list of diseases that drove us all, and problems and conditions which were challenging us in the 70s, 80s and 90s, how did we fare? Well, we failed in developing a capacity to detect the next thalidomide, not because of our data, but because the Federal Department of Health blocked us from linking then all the birth defects, because we'd had started registers in every state and territory, they stopped us linking that to the pharmaceutical benefit scheme. It would have delivered a capacity for the rapid identification of the next thalidomide or other drugs that were causing problems in pregnancy, as well as things like carcinogens and so on. So that was an extremely anguishing time for us, and we've since changed that. However, with Carol Bauer leading, we were part of the international collaboration to discover that diets rich in vitamin folate in early pregnancy could prevent up to 75% of spina bifida, encephalocele and encephaly and related defects. And by 1990, we had the first evidence from international randomised controlled trials and other cohort studies, and Carol Bauer implemented the world's first population health promotion program to reduce spina bifida births in Western Australia. It worked in white, healthy, planned pregnancies, but not in First Nations, smokers, unplanned pregnancies, and poor mums. This led us to lobby to mandate to have folate added to the flour. In spite of the international evidence, the Australian Health Department and the flour industry tried to stop this and took us 9 long years to get it approved. And of course, we had to, the only thing you could do to prevent spina bifida before that was to have antenatal testing and termination of pregnancy. But of course, we had to add those in to our register so that we could properly evaluate the impact of the folate campaign. We showed that the rates of developmental disorders in very preterm births who had been resuscitated were high, and we worked with neonatal and developmental paediatricians to identify risk factors. The rates are now falling due to much better intensive care management of all the complications like intraventricular hemorrhage and necrotizing colitis, etc. We challenged the myth that most babies born at term who develop cerebral palsy have birth asphyxia as the cause. Obstetricians had naively claimed that the new tool of electronic fetal monitoring followed by caesarean section would reduce the rates of brain damage. They promised the perfect baby, which was a bit stupid of them because, in fact, they've got sued to Kingdom Come for not doing that. In fact, it had no impact at all, as we showed. Most cases of newborn encephalopathy resulting in later cerebral palsy had damage which occurred early in pregnancy or even was a genetic sort of polygenetic cause. This work was done by Nadia Badawi, Eve Blair, Linda Watson, with Karen Nelson from NIH, so it's really important to have the wonderful international collaborations. With adolescent suicides, Steve Zurbrick and Sven Silburn used their complete suicide and self-harm data to show that the big risk factors for suicide were having attempted before, being an Aboriginal male, and substance abuse. They noted that most cases of self-harm presenting to the emergency departments in Western Australia were not given any follow-up. We were going to do an RCT on the randomised controlled trial on this, but then the hospitals refused to randomise, so we implemented a program to get these young people to appropriate services once they self-harmed. This may sound like old news now, but in the 1980s, when we were only starting to be concerned about mental health, and of course adolescent mental health and child mental health was completely neglected and ignored. Now the suicide rates in adolescents are still high. They're rising in particularly Aboriginal populations. The risk factors are the same. We know about what to do. We have a crisis in mental health, but there's been a shift towards older adults as well having suicide. So young adult men are now suiciding at high rates. The most powerful data that we've used, I guess, for translation has come from 2 big studies, the WA Aboriginal Child Health Survey and the WA Aboriginal Child Health Survey in the late 90s for the first and the early 2000s for the other. And these clearly showed, along with a lot of research that's been done internationally, that pregnancy and early childhood situations, particularly poverty, where you were born, and maternal, who you were born to, your maternal characteristics, were important for a range of child and youth outcomes which actually influenced your whole life cycle. And hence we had evidence for the preventive power of early childhood interventions. We developed and tested an index of child development, which is now national, and all 5-year-olds now part of the Australian Early Development Census. Well, we stole that from the Canadians in British Columbia with their permission, but they got very pissed off because we had it a nationwide before they did. In fact, they still don't have it. It's still province by province in Canada. But that's really very helpful because you can evaluate the impact of early childhood services across the whole nation, as well as identifying where they're failing, so you can do the sort of geographic kind of look at this. You can link it into NAPLAN results to see how predictive entry to school competencies are for NAPLAN and later problems. So it's a really exciting, very important area of research, and we're still having to bloody lobby for it, but there we are. This is the slide which I showed. I was actually served on the Prime Minister's Science, Engineering Innovation Council, which was fantastic. And so I gave a presentation on the importance of early childhood. But in order to convince John Howard, who was the Prime Minister at the time and chairing this council, I had to turn children into economic successes. But when you think about it, it's absolutely true. So if you have most children commencing their lives in environments which enable full opportunities for healthy child development, you have most children mentally and physically healthy, reaching their potential, most young people participating to their full potential, and you have this intellectually competent and emotionally capable workforce with national economic prosperity, particularly in a world which is looking at, in these days, this was, the 1990s I was giving this presentation, and, the technical, the needs to be technically competent and well-educated were very important. But the other bit that I put in was the health and welfare budgets were not going to drain Australia's capacity. The mental health budget, the health budget, the disabilities budget, all of the things, including things like incarceration and detention of kids who've gone off the rails, remedial education. But then also you have a next generation of parents socially and emotionally competent with cycles of economic prosperity and national capacity, Prime Minister. Anyway, he got it, which was really good, and we got early childhood up. And of course, when Julia Gillard came in, she actually put this high on her agenda as well. But the WA Aboriginal Childhood Survey provided the first national data on the extent and effects of forced removal from children from their families and from land. Between 40 and 60% of communities in Western Australia, with 90% response rates in this survey, by the way, it's the best response rate we ever had, and that showed that Aboriginal people trusted us with their stories, so it was a huge responsibility to try and make a difference. We showed that this high rates, 40 to 60%, had been stolen, but the impact in subsequent generations on mental health, substance abuse, gambling and crime were noted across these generations, up into the third and fourth generation. So that trauma that Aboriginal people talk about is real. After presenting these data, and this again was in the Howard era, to the Canberra bureaucrats with a real plea for doing something about this, they refused to believe the data. We had to reanalyse it all over again and write 3 more papers to present to them. And of course, we've just used the data last year when Jacinta Namatjira-Price said that colonisation had been good for people because you had running water, and we were able to show that colonisation had been devastating for Aboriginal children today. So I think that was really important. Our easiest translation of research came from our total population study of Hib disease, Haemophilus influenzae type B, which causes meningitis, causes still meningitis, if you get it, respiratory problems, epiglottitis, and ear disease. Australia was contemplating a toddler vaccine for Hib. Geoffrey Hanna and Jan Payne developed a graph with the help of the drug company Merck, so we were involved in a little bit of the drug company research as well, mostly randomised trials of vaccines. But it clearly showed that by the age of 3, 100% of Aboriginal kids and 75% of white kids would either have died or developed disabilities from Hib or survive without problems. We showed this then to the then Health Minister in WA, Peter Foss, who immediately changed the strategy and bought a huge amount of infant vaccine from Merck. It was a great feeling, actually, looking at our data after that, to just see meningitis and Hib disabilities and deaths disappearing from Western Australia. The Australian cot death story is another success, great success. Terry Dwyer had conducted a small cohort study in Tasmania, which confirmed all the previous less rigorous case control studies, which have got a lot of bias in terms of bias from interrogation. It showed it cleared that prone lying, tight swaddling and smoking were risk factors, and breastfeeding was protective. At a national meeting to discuss this, Judith Lumley, who was another great epidemiologist in Melbourne, and I said it needed to be trialled. We should trial this changing the lying, et cetera, et cetera. But we were shuttered down basically by the rest of the group. And of course, the national program had a dramatic effect in reducing cot deaths, which of course we monitored in the WA data, and Red Nose Day, which was a big funding for cot deaths, now funds other research. In relation to infertility treatments, we've had an impact. We showed that triplets and higher order births following IVF and GIF were at much higher rates of CP, cerebral palsy, and this changed the practice of embryo transfer. Clinics were not accredited if they put back more than 2 embryos. So that was like I think accreditation is quite a neat way to change people's service provision, and I think particularly so with Aboriginal services, but I haven't got time to go into that now. Well, what about our work in First Nations health and wellbeing? I guess this has been one of my biggest passions, and I guess I'm really proud of what the Institute has done here. When we set up the Institute, I went to the Aboriginal community-controlled health organisations in Western Australia, and I said, what do you want us to be for you? We're not a service provider, we're a research institute. And they said, we want you to be our mother. Well, what does a mother do? A mother trains her children, gives them all the love, the information, the knowledge, the funds, the capacity, so they can go out and cope in a really challenging world and be successful. And we did just that. And we've trained an outstanding group of Aboriginal scholars who are now leading their own research and training, and the next generation of First Nations scholars as well. So when we got the first NHMRC capacity building grant, after that 5 years, I said, OK, all of you have now got your PhDs, you've got to go out and get 2 more Aboriginal PhD students. So it's just been amazing. And of course, they're all doing really top research, which is incredibly relevant. And I think that's it's just been a fantastic commitment from everyone in the Institute. But working so closely with First Nations people, I learned so much about their thinking about causal pathways in health and wellbeing and the different methodologies that they use, like community participation, action research methods, and yarning. You have to have a yarn with an Aboriginal person before you ask them ask questions about for collecting data. And of course, Sandra Eads, who's here at Melbourne University, got a personal chair, changed the NHMRC to be more supportive of First Nations research, a whole lot of roadmaps that she developed in the 90s and 2000s. So this sort of thinking, a broadening of the thinking about what health and wellbeing meant, led me to realise that our approaches could be used more broadly. That the majority of pathways into our wellbeing were complex and needed a preventive approach. Waiting until the suicide, the educational failure, the child maltreatment, the young person in detention was too late and very expensive. The most cost-effective and humane way to tackle most of the wicked societal problems, we felt, was to identify causes and intervene early before they became irreversible. Hard to treat, expensive for society, and anguishing for families. So the next one is what this is, again, a very old slide that we did a book in 2005 about children, and the kinds of things that are very positive for children's development are on your left-hand side, and the things that are interfering with that are on this side. And what's important is that whilst you have a child and a family and a community and there's the things in the outer circle are the ones which influence the ability of parents to be good parents or not, or for a child to grow up healthy and well or not. So all of these things that are happening in our uncivil society, I don't need to read them all, but you can see them. Where are we now in Australia? I mean, this is an old slide, but my sense is that we need to really start thinking about what communities need to be in terms of a civil society if we want to get children to grow up healthy and well. And it's easy for me to say, well, we need to have prevention, we need to have early intervention, we need to avoid climate change, all these things. But what we did once we started to think this way is that we collaborated with many of the WA bureaucracies, all of the departments, to add education, child protection, public housing, police and justice to our database. So our cohort now, which started in 1980, still ongoing, you can actually follow an Aboriginal child from conception, and some some grand parental information right through to juvenile justice and detention. So you can look at the pathways that you haven't done anything about and failed to change these pathways for Aboriginal children. So that cohort is incredibly rich. Rebecca Glaude and Melissa O'Donnell, two of my wonderful postdocs, did a lot of the pioneering work to use these data for things other than medical things, like child protection and justice, the juvenile detention. And I wonder if I'm naive to suggest that these approaches can be used to tackle many of the major issues now facing us on the planet. Climate change, increasing inequalities, damage to the environment, loss of species, obesity and its chronic disease impact, substance abuse, domestic violence, and even violence within and between nations. I wrote these words before the invasion of Ukraine and the horrible situation in Gaza. And we have Melbourne University's been supporting a project which I've been working on for far too many years, which is about changing GDP as a measure of successful societies and bringing other well-being measures so that we can say that what we really are going to invest in are those things which are going to make our children healthy and well in the future. So with this new Labor government now in Canberra, not so new, but and all the Teals and the Greens, I think we've got a much greater chance of getting that sorts of thinking up. So I just want to mention one more thing before I finish, because it's about the COVID pandemic, and I just want to let you know that we did lots of analysis of the data during COVID for Aboriginal populations. And of course, everyone thought they were going to do very badly because they're high rates of chronic disease, they've got poor living conditions, they have not got good hygiene, they don't have good health literacy, all those things. Well, actually what happened was that when we looked at all the data for 2020 and 2021, Aboriginal populations had 6 times fewer cases than we did. And it was a complete reversal of the gap. And the reason that they did that is because at every level, from NATCHO, which is the National Aboriginal Community Controlled Health Organisations, right down to community, they knew what to do. So many Aboriginal public health physicians now trained, so many people in public health, Aboriginal health workers, and they just swung into action. And they had a seat at the table, and they lobbied to close communities. Only 20% of Aboriginal people live in remote communities. Most of them were living in cities where it was extremely risky for them. They got people off the streets, they got them into good accommodation, they provided medical care, they had telehealth. It was amazing. Could we get it out into the media? No way. We got it into the Lancet, we got it into the overseas media, we wrote to some of the, the Guardian and so on. They put some of this in. But, it then became really urgent because we wanted to link it to the explanation for a voice, of why a voice would be so important. To put Aboriginal people in charge of services, and they work. Marcy Langton and I wrote an article, sent it to the Sydney Morning Herald, and the editor rang us back and said, if they did so well without a voice, why do they need one? I thought, shit. Anyway, there we are. So thank you for letting me read to you about my... I've rambled on really about my down memory lanes, about my career, but I just want to acknowledge that the reason that I've been so successful is that I've had the most amazing groups of people around me who've really done all the work. So it's been a ball, it's been a joy, and I feel so lucky. So I wish you all well. I hope that you get inspired by some of the presentations today and think, yes, I can do it. And I want to do it, and I'm going to make the world a better place if I do. So thank you very much for listening.
A career full of impact. I hope that was inspiring to you, as it was to me, highly. We have time for a couple of questions.
Radio. This one's too, yeah.
Hello, my name's Evie. I just wanted to thank you, Prof. Stanley, for your talk. It was very insightful and actually inspiring. I do have quite an interest in public health and epidemiology. So I wanted to ask you, so much of what we do involves communicating with the public and stakeholders like the government and industry. And you've mentioned that there are many struggles that come with that. I just wanted to ask, how have you and your team managed these so that you've gotten these changes implemented? Because it has been hard.
Brilliant question. Brilliant question. And it's been, I guess, the biggest challenge. Because while you say, yes, we have been successful, it's anguishing when you do research and you know how important it is. And it really sort of is the truth, I think, Sam. We can just say that, you know, that if you did this early in life, Aboriginal kids would do better. But getting the bureaucrats to take that on board and the politicians is really hard. So I think I do a lot of mentoring, and a lot of the mentoring I have is with people who want to be in that advocacy space. So I've got quite a lot. There's something on the College of Physicians about advocacy. And that sort of got all the sort of clues and what to do, but also the failures and the anguish that comes from that. But I think what you have to do is you have to absolutely have the data ready. You have to do it really well. You never, ever speak about something unless you've got absolutely solid evidence for it. And that's a really important point about advocacy. But the other thing to do is get around you people who can speak for you and with you. And the people who are honestly the best for that are consumers. And so the consumer voice, which has changed radically over the time of my research life, has been fantastic. And I think, you know, using consumers as your advocates is really important. But it's also helpful to have a political advocate, a bureaucratic advocate, you know, a passionate media person that get those community people on board. But communicating science to the community is also a really, really important aspect of our work. We need to do that. I mean, Sam's made the point about we need funding, but one thing you need to do is say, well, why are we so important to fund? What is it that we do that's so important? And you have to put that into, you know, I'm not very good at giving the sort of the 10-second bite that they want on television. I love it when you have a more a media person who's going to interview you for half an hour. But you've got to be ready to sort of get those messages out as quickly as you can. The other thing that helped us enormously in Western Australia was Telethon, which is a Channel 7 program, 24-hour program to raise money for children's research and children's care. And the coverage is huge. So 500,000 people watch Telethon. And if we go on and talk about our research, it gets out to all those people. So that was actually, you can't recreate that anywhere, but it's amazing. It was a fantastic way of getting information out. But great question.
Yes, science communication is part of our day job. It's not something for someone else. You have to be good at it and you have to engage the community. And I mean, I think your work really shows that at its greatest level, doesn't it?
But what I do with a lot of the people that I mentor is I say, well, go and get some training from either an actor or a speech pathologist about speaking. And we actually have people coming in, and I don't know if you're probably all too young to know about John Cleese, but anyway, if you want to see what not to do, watch the John Cleese video about giving the speech. And he stuffs up, of course, everything, but by stuffing up, he shows you how really you should do it. But I don't think you should say, well, I'm not... Don't be shy about going and getting training about how to give a good talk. It's really important. It's important for your research career. It's important for your public face. It's important for fundraising, everything.